Hi everyone, I'm Dr. Roman and I'm a hematologist oncologist, and today we're going to go over colon cancer and rectal cancer, collectively known as colorectal cancer. Although there are some differences, we're going to go over all these differences and everything that I think you need to know. Now, the first thing is there's a lot of information we have to cover. And listen, you need to know all of this. And I'm going to go over the basics. And the whole reason for this video is to prepare you to have that important conversation with your oncologist, with your doctors. Because if you don't know this, then you're not going to understand and be able to follow along when your doctors are recommending whatever treatments at that time. So that's my goal here, to prepare you. Now, there's a lot of information, so you have to tough it out with me, and I promise you that towards the end, everything's going to make sense. I also encourage you to find your blood tests, find your pathology results, your imaging studies, so you can follow along with me and everything starts to make sense to you. I have to tell you, as the slide says, at times you will feel discouraged, but please trust me. I'm going to give you all this information, and at the end, everything comes together. It makes sense. So tough it out with me, and believe me, you will be surprised at the end how much you learned by watching this video. Also remember, I am not your doctor. This is for educational purposes only. I am not providing medical advice. And the last thing, I'm going to ask you for a favor. If this video helps you, please like, consider subscribing, leave a comment. This way, I know that you're enjoying this video, that it helped you, and also it moves it up on the algorithm so other patients are able to find it, and also I'm able to help them out. So with that being said, let's get started. So let's start off with the anatomy of your colon. And believe it or not, you really need to know this for multiple reasons. So looking at the picture here, we have the first part of your colon, known as your cecum, is right over here. And on the cecum, we see the appendix. Then you have your ascending colon, transverse colon, descending colon, sigmoid colon, and then the last part of your colon known as your rectum. So this is the rectum down here. Just know that the rectum, if you have rectal cancer, it is treated slightly different than cancer in another part of your large intestine. So number one, you need to know that. The other thing that I want you to know, believe it or not, we divide your colon into the right half and the left half. So your cecum, your ascending colon, and the first part of your transverse colon is known as the right side of the colon. And then the latter part of your transverse colon, descending colon, and sigmoid are known as the left side of your colon. And this is important because if you have colon cancer, depending on if the cancer is located on the right side of your colon or the left side of your colon, it has both prognostic and therapeutic implications, which we will go over. Now here, I also want to show you that around the colon, okay, you also have these little green structures that you see. These are lymph nodes. And it's very important that you know about lymph nodes. See, we have them all over the body, but here you see that the colon, all around your large intestine, we have lots of lymph nodes. And this is important because colon cancer usually starts in a polyp. That polyp grows, it starts invading into the colon, and then it spreads to lymph nodes. And that's very important because when you have surgery, we evaluate these lymph nodes, and that also has very important therapeutic and prognostic information. So let's move on to what we call staging. And the first thing, if you've been diagnosed with cancer, the first thing your doctor is going to want to know is, has this cancer spread to another part of your body? Something that we call metastasis. So the first test that your doctor will likely perform to help exclude this is some sort of a picture imaging test. And the most common one that we use are a CT scan and a bone scan. So we will perform a CT scan usually of your chest, abdomen, and pelvis with IV contrast if possible, as well as a bone scan, because we want to make sure that, again, you do not have cancer elsewhere, because unfortunately colon cancer likes to spread to your intra-abdominal cavity, your liver, your bones, your lungs, just to name a few of the more common locations. So we want to try to find this. Now, it's important to keep in mind that any picture, it doesn't matter if it's a CAT scan, a bone scan, a PET scan, In order for you to see it on one of these tests, it has to be macroscopic. It has to be large enough for you to see it. So I say this because a lot of times, patients say, well, I had my CAT scan and nothing showed up in the liver. So I know 100% that there are no cancer cells in the liver. Unfortunately, that's not the case because, again, remember, these pictures will show you macroscopic disease, not microscopic disease. So you can still have microscopic cancer cells that have spread, and it will not show up on any imaging test that you did. And that's why a lot of times after surgery, a doctor will recommend chemotherapy to try to remove, if you have some of these microscopic cancer cells, to try to kill these cells off. So something that you always need to keep in mind. So going back to staging, if you have rectal cancer, your doctor may also recommend a pelvic MRI or something that we call an endoscopic ultrasound, where they insert a rectal catheter with a camera that has an ultrasound. And again, this is just to get better pictures of your rectum to try to see how involved is this cancer within your rectum. These are all tests that we have at our disposition that we use to try to stage you as appropriately as possible. The next thing we're going to move on to is your TNM staging system. And I know, again, I'm giving you a lot of information. Trust me, number one, you need to know this. And I promise you, I'm going to go over this now and in the next few slides, and it's going to make sense to you. If you had surgery, I encourage you to find your pathology result, and we're going to go and you'll find these numbers on your path result, and then you'll know exactly what I'm talking about. So the TNM staging system is something that we use to try to ultimately see how advanced your cancer is, or what is the risk of your cancer coming back. I mean, it gives us a lot of information, and it's called the TNM system. And T stands for tumor, N stands for lymph node, and M stands for metastasis. Now, the T, let's concentrate only on the T here. It can either be a tumor in situ, being the earliest form of carcinoma or cancer that you can have in the colon, or T1, T2, T3, and T4. We're going to go over examples of these, each one by one, so you know what I mean. Then the N stands for lymph node. N0 simply means that when you had surgery and these lymph nodes were removed, none of them were involved with cancer or by cancer, and that is excellent. N1 means, yes, we found cancer in a lymph node, but it was either 3 lymph nodes or less with cancer. And N2 means that you had at least 4 or more lymph nodes. And again, the more lymph nodes you have involved with cancer, the worse it is. It's just common sense. NX simply means that lymph nodes could not be assessed. So maybe you had surgery, they removed the area, but the pathologist did not find lymph nodes for whatever reason. So that's what the NX means if you have an NX on your pathology result. Now the M stands for metastasis, and this is really more for the oncologist or the surgeon to determine, because a lot of times M0 of course stands for no evidence of metastasis. M1 stands for metastasis. So for example, if I do a bone scan and I know you have metastatic cancer to your bone, then I already know, even before looking at the pathology result, that you are an M1, meaning you have metastatic disease. And MX means that metastasis cannot be assessed for whatever reason. All right? All right, so now let me show you examples one by one of the TNM staging system. So this that you see here, this is the colon, and this is a cross section of the colon where it was cut in half. In other words, this out here, this is the outer part of the colon, and this is the inner portion of the colon. So the colon is this is the inside, this is the outside. The colon has several layers. The mucosa, right here. Then you have the submucosa, right here. Then you have the muscular layer, right here. And then you have the outermost part, which is the serosa. Now, keeping that in mind, if you have cancer only in the mucosa, you have a tumor in situ, which means intramucosal cancer. Very early, this is usually when cancer is found within a polyp. So you had a colonoscopy, they found a polyp. Unfortunately, you had a little cancer in it, but it's a tumor in situ, very, very early cancer. Now, if you have cancer that's involving the submucosa, and it's only within the submucosa, okay, so it's mucosa and submucosa, it's T1. So it's already invading the submucosa. If that cancer went and penetrated the muscular layer, but it did not go through the muscular layer. So it started in the mucosa, submucosa, and went into the muscularis, but it did not go through the muscularis. That's a T2 tumor. And if it went through the muscular layer, then it's a T3 tumor. And of course, if the tumor penetrates the whole wall of the colon and it goes into the peritoneum, which is our abdominal cavity, and or it's directly penetrating an organ that's right next to the colon, then it's a T4. Now, I want to make a little emphasis on T4. Remember, this tumor starts on the inside of the colon. It starts penetrating as it grows. It starts growing into the colon, going through the submucosa, the muscularis, the serosa. And then if you're, as an example, let's say your liver is right next to your colon. These organs are touching each other inside your abdomen. And if this tumor goes into and grips the liver in this example, that's a T4 tumor. But it can also be a part of your small intestine, your spleen, whatever the case may be. That means you have a T4 tumor. So keep that in mind for the next slide. Now, your doctor is going to want to know, what stage of cancer are you? Are you stage 1, stage 2, stage 3, and stage 4? This is the number that you want to know. And in order to know what stage you are, you need to know the T and the N. Because if you don't, then we can't appropriately stage you. That's why you need to know this. So for stage 1, which is the most early form of colon cancer, you have to be either a T1 or a T2 with negative lymph nodes. So T1 or T2, N0, you're a stage 1. Now, if you are a T3 or a T4 with negative lymph nodes, you're a stage 2 colon cancer. If you have a positive lymph node, of course, 1, 2, 3, however many, known again as N positive or N1 or N2, you're a stage 3. So I don't care what your T stage is, what the T number is. If your lymph nodes are involved, you're automatically a stage 3. And a stage 4 means M1. Again, you have metastatic disease. We know you have colon cancer. We did an imaging test, and unfortunately, we found a mass in the liver or in the lung or your bone, whatever the case may be. You have metastatic disease. You are a stage 4. And by definition, most, but not all, stage 4 colon cancers do not have a cure. And unfortunately, I have to tell you that because it's the truth, and this is something that you need to understand. And this is how we stage a person. So we use pathological information from your surgery and imaging information from your CAT scan, your bone scan, whatever. All right, so now some other important information that you need to know. And that is, and you need to ask your doctor this question, the number of lymph nodes removed during surgery. This is very important. If you can imagine, the more lymph nodes are removed during surgery, the better the N staging will be. That's why the TNM is very important, because the more lymph nodes they took out, the more lymph nodes we can evaluate, and it's common sense. So we want to see, or we like to see, at least 12 lymph nodes. And if you have more than 12, even better. The problem is, as I said, sometimes, for example, maybe the surgeon did not take out as many lymph nodes, or more commonly, maybe you were born, your anatomy, you simply did not have that many lymph nodes in this area. Or the pathologist, when they were evaluating your specimen, maybe, usually does not happen. Pathologists do a very good work usually. But maybe they just did not take the time to dissect and look for these lymph nodes. For whatever the reason, ask how many lymph nodes were removed, or look at your pathology result, and you will see, they will tell you 20 lymph nodes were removed and so many had cancer. So usually we'll say something like 5 out of 15 lymph nodes were found. So there you know the patient has N2 on the TNM staging system. Or maybe they'll tell you 0 of 18 lymph nodes were found. So now we know you're an N0. See that? Now you're getting it. It's starting to make sense to you, as I promised. So moving along, I also told you that you need to know if your cancer was on the right side of the colon or the left side of the colon. Very easy, just ask your doctor. Or if you read your pathology result or your imaging test or your colonoscopy and they tell you it's in the cecum or the ascending colon or the proximal portion of your transverse colon, you know it's right side. If they tell you it's in the descending colon, the sigmoid colon, then you obviously know the tumor is on your left. And why is this important? Well, number one, unfortunately, right-sided colon cancer tends to be more aggressive, so it has a little bit worse of a prognosis, and it's also less likely to respond to chemotherapy and another treatment that we call EGFR inhibitors. And don't panic, we're gonna go over these, but I just want you to know that the right side, if you have cancer on the right side of the colon, unfortunately, it tends to be a little more aggressive and it tends to be a little more resistant to treatment. That's why it's important for you to know. All right, so moving along, starting up here, obviously you know now that you need to know, do you have colon cancer or rectal cancer? Because treatment will differ somewhat. I put mutation testing here. Very simple. Every cancer starts or originates because of a genetic mutation. Sometimes it's one mutation, maybe it's multiple mutations. It could be because of age, maybe your diet, predisposing factors, whatever the case may be. In the case of lung cancer, for example, maybe you were a heavy smoker and that damaged your DNA, resulting in a mutation. So in colon cancer, there are certain mutations that we can test for that if you have a specific mutation, we have potential treatment options for that mutation. We're going to go over these in a little bit, but that's why a lot of times, especially if you have metastatic disease, we might test you to find a possible mutation that we can treat. Now, unfortunately, sometimes they do find mutations that we do not have treatment for. But it's very important that if you do have a genetic mutation or a specific protein that's being expressed in your cancer, we find it, because if we have treatment options, we want to exploit and be able to give you that treatment. And these are some examples: KRAS, the HER2 protein, the BRAF mutation, NTRK. So these are some of the mutations that we want to find. There's also something that we call microsatellite instability. And I know what you're thinking, satellite, what? Now we're talking about outer space. And it's confusing, but it's quite simple. The majority of patients, unfortunately, do not have MSI high. It's what we call MSI high. But if you do, you might respond to immunotherapy. That's right. We have medications that stimulate your immune system to attack the cancer cell. So in short, this is what I want you to ask your doctor. Do they need to test you for a mutation test? Okay, because sometimes we do, sometimes we do not. But if you have metastatic disease, we usually do, because we want to know, do you have one of these treatable mutations? And ask your doctor, do you have microsatellite instability? So you're either going to be, yes, you have microsatellite instability, or you're microsatellite stable, meaning immunotherapy is not likely to help you out. Very important question to ask. So now let's move on to surgery. Obviously, the most important treatment for colon cancer is surgery. And these are the questions that I would ask if I required surgery. Just know that you have two types: minimally invasive and open. Minimally invasive, as the name states, it's to try to traumatize your body as little as possible. So with minimally invasive surgery, there are two types: robotic and laparoscopic. In robotic, the doctor will put these robotic arms in your body through a small little incisions on your abdomen, and then your doctor will sit elsewhere on a computer monitor controlling those robotic arms, and that's why it's called robotic surgery. It's usually with a machine called the Da Vinci machine. In laparoscopic, the doctor will insert the same thing. They'll open some holes and they'll insert some arms, but the doctor is standing next to you. The doctor is holding these arms and they're performing the surgery right next to you, looking up at a TV screen, okay? So they're both forms of minimally invasive, and the good thing about them is that the incisions are smaller and usually the recovery time is a lot quicker. So the other one is the open surgery, where the doctor needs to make an incision where the incision is larger, and they will perform the surgery using their hands. So ask, if I had the option, I prefer minimally invasive, but unfortunately sometimes the surgeon has to perform an open because maybe you perforated or maybe you have a very large tumor, whatever the case may be. Maybe you're not a candidate for minimally invasive surgery. So ask what type of surgery if you will be undergoing surgery. Chemotherapy. All right, you need to know these basic topics, and that is neo-adjuvant, adjuvant, and palliative. And believe me, if you use these words with your doctor, they will know you've been doing some reading. And it's very simple. Neo-adjuvant means the doctor wants to give you treatment before surgery. So in other words, maybe you have a big tumor in your rectum and your doctor wants to shrink that tumor to make the surgery easier. That's called neo-adjuvant. Adjuvant means after surgery. So let's say you had surgery and the doctor wants to give you, your oncologist wants to give you chemotherapy to try to prevent this cancer from coming back. Remember when we said microscopic? That's right. Maybe you have microscopic cancer cells somewhere else in your body that we cannot see, because remember, the CAT scan, the bone scan, a PET scan, none of these tests will detect microscopic disease, and then we will give you chemotherapy to try to eradicate these potential cancer cells. And adjuvant treatment, obviously, is to try to cure you, and we give it for an amount of time. In colon cancer, it's usually anywhere between 3 to 6 months of treatment post-surgery. Palliative, on the other hand, is we know you have metastatic disease, and we want to give you therapy to try to prolong your life and to try to improve your quality of life. And believe me, a lot of patients tell me, how the heck can chemotherapy improve my quality of life? Because everybody gets sick with chemo. And let me tell you now, that is not necessarily true. I have patients that undergo chemotherapy for colon cancer, and most of them tolerate it fairly well. Sometimes we have to adjust, and sometimes we have to change the treatment. But that's a conversation you will have with your doctor. But I can tell you that most patients do relatively well with chemotherapy for colon cancer. Because in general, colon cancer chemotherapy is not as aggressive as other types of chemo that we use for other types of tumor. And I'll tell you something else. A lot of times you don't even lose your hair. So alopecia typically, although it can, but it typically is not a major issue in colon cancer treatment. So there you go, a little plus. Now, as far as treatment is concerned, I already told you surgery is the most important part. Now, let's say you had surgery and we know based on the pathology result and the imaging test that you have a stage 1 cancer. Remember, you're a T1 or a T2, N0, M0, no chemotherapy. We're done. A stage 2, which means, remember, you're a T3 or a T4, N0, M0, we usually do not give chemotherapy, but there are exceptions, and that exception is if you have high risk features. I'll give you some examples. Let's say that you had less than 12 lymph nodes evaluated. Remember, we like to see at least 12. So if you have less than 12 lymph nodes evaluated, we might feel a little uneasy that maybe, maybe just maybe you are higher risk. That would be an indication. Another one would be if you have T4 disease. Remember, T4, that tumor is already invading. It might be invading other organs. So obviously, T4, when you go back to the TNM, the T4 means you're higher risk. So in those cases, we consider them higher risk stage 2. There are others that you can, you'll speak to your doctor. But if your doctor tells you, well, you need to know that you have stage 2 colon cancer, the next question should automatically be, am I low risk stage 2 or am I high risk stage 2? Very important, because a high risk stage 2, even though it's a relatively early stage, we might recommend adjuvant treatment. See, now you know where these words come from and how we use them. Everything's making sense. Stage 3, remember, you have a positive lymph node, at least one, so you're N1 or N2. In these cases, we usually recommend chemotherapy unless you don't want chemo, unless we don't think you will tolerate chemo. Maybe you're older, maybe you have a lot of comorbidities, and we do not think you'd be a candidate for chemotherapy. But if you're strong enough for chemotherapy, you have stage 3 colon cancer, we usually recommend adjuvant chemotherapy. And obviously, for stage 4 or metastatic disease, we do recommend chemotherapy to prolong your life and improve your quality of life, as we already said. Now, radiation therapy. Remember when I told you there are differences between colon and rectal cancer? Here goes. In cancer of the rectum, it's the last part of the colon, a lot of times the doctors will want to give you chemotherapy and radiation first. In other words, neo-adjuvant chemoradiation followed by surgery. There are many reasons for this, but the most important part is if you have cancer in the rectum, there's a chance that with surgery, you may lose your anus and require a permanent colostomy bag. You know, a little bag that will be connected to your abdominal wall. We want to try to prevent this from happening. So a lot of times, by giving chemotherapy and radiation first, we can shrink that tumor, and now it will be a lot easier for the surgeon to do that surgery and hopefully spare the need for a colostomy bag. So that's the main reason that us doctors recommend for rectal cancer, chemotherapy and radiation first. In other words, neoadjuvant chemotherapy and radiation followed by surgery. The last thing I want to go over here is metastasectomy. Very important. If you have metastatic disease, so if the doctor tells you, unfortunately, you have stage 4 disease, you have metastatic cancer, the next question is, could you still be cured? Now, in all transparency, this is rare, but our job as doctors is to try to save your life, is to try to cure you. So there are times, I'll give you an example, this is where we usually see it. Maybe you have colon cancer that has spread to the liver, and it's a small little area of the liver. We can sometimes resect, in other words, have surgery and remove that tumor, metastasectomy, and hopefully cure you. So if you have stage 4 disease, the next question should automatically disease, could you possibly still be cured? Are you a candidate for a resection of the metastatic cancer? And the doctor will tell you either yes, you are, or no, you are not. Hopefully, if you're metastatic, the answer is yes, obviously. All right, very busy slide, and most of you will freak out right about now, but listen, don't. I'm gonna go over it, and believe me, it will make sense to you. Very, very simple, okay? And you have to simply find on this slide, where do you fall in? So let's start off with neoadjuvant therapy. I'm repeating it so you memorize it. Neoadjuvant meaning before surgery. It's usually done for rectal cancer together with radiation therapy. So here the medications that we use is either 5-FU, which is 5-fluorouracil, or capecitabine. Just know capecitabine is oral 5-FU, which is given together with radiation therapy. We use the chemotherapy, in this case is called a radiation sensitizer because it helps the radiation work better. And again, we do this in rectal cancer. Now, the main side effects of 5-FU is nausea. It can give you mucositis, the little lesions in your mouth, which is not that common, but it can happen. It can also give you diarrhea, upset stomach, many other potential symptoms, but just know that these are the most common. Capecitabine being oral 5-FU, it's the same ones that we already mentioned, but it also has a unique side effect, which is called hand-foot syndrome, where you start to get a rash or a discoloration in the palms of your hands and the soles of your feet. And it usually happens when you've been taking this medication for several weeks. And you'll notice a lot of patients start complaining of redness or just symptoms on the palms and soles. It's known, it's due to the capecitabine, also called Xeloda. And just know that, it can definitely happen. Now, adjuvant therapy. Remember, adjuvant is after surgery. We want to give you chemotherapy to try to prevent this cancer from coming back, usually given anywhere from 3 to 6 months. Again, the same medications, 5-FU and capecitabine, but we can also use another medication called oxaliplatin. The issues with this medication is neuropathy, that tingling, numbness sensation that you get in your hands and feet, typically seen in diabetics. That's neuropathy, and you can get it with oxaliplatin. It also has a unique side effect of cold intolerance. So if they're giving you oxaliplatin, be careful if you drink something cold or if you touch something cold, usually the first few days after you get a treatment, because it can cause cold intolerance and also other side effects, but that is the main one. Just know that there's another regimen that's called CAPOX. Very simple. All CAPOX is capecitabine together with oxaliplatin. So CAP for CAPE and OX for oxaliplatin. That's all that is. We're using 2 drugs, 2 chemo drugs. The other one is FOLFOX, FOL-FOX, and this is 5-FU together with another medication that's called leucovorin, which is really a vitamin, together with oxaliplatin, and we call it FOLFOX. That's it. These are the most common regimens used for adjuvant therapy, meaning after surgery. Now, for metastatic disease, stage 4, M1, whatever you want to call it, we have many different options. Once again, same medications, 5-FU, capecitabine, oxaliplatin, and the already mentioned FOLFOX, etc. All these same regimens that we already went over. But we also have several others that we're going to go over now. Really quick, irinotecan is another one, okay? The main side effect of this medication is diarrhea. Fortunately, it does have GI issues, so that's the main side effect. If you combine irinotecan together with 5-FU and leucovorin instead of FOLFOX, it will be called FOLFIRI. That's all it is. See, but it's the same medications. There's also another drug that we use, and this is an antibody called bevacizumab. What this does is that this attacks the blood vessels attacking your cancer. So a lot of times bevacizumab will do that. It's an antibody, and it will attack these blood vessels. And the whole idea here is to try to prevent blood, which is full of nutrients, from reaching the tumor. And we can also combine bevacizumab with some of these other drugs. So we combine them. So, ask your doctor which combination or drug or drugs with an S are they going to use. We also have oral medications like regorafenib, trifluridine. Just know that there are many different treatment options. This is not to confuse you. I'm just telling you, I call them bullets. We have a gun, and the more bullets we have, each one of these medications being a bullet that we can use to attack your cancer, the better off we will all be. Now, remember when I told you the mutation test? This is why we need to know, because very important for you to know this. If you do not have a KRAS mutation, that's why we call it KRAS wild type, WT, meaning you do not have KRAS. BRAF wild type, you do not have these mutations. The tumor is on the left side of your colon, then you are a candidate for a family of medications called EGFR inhibitors, known as cetuximab and panitumumab. Don't freak out. Again, either you have the mutation or you do not. If you do not have these 2 mutations, the KRAS and the BRAF, and the tumor is on the left side of your colon, you're a candidate for these medications, period. Now, there are sometimes we can still use them, combining them with other potential treatments, but that's way above this video. But just know that this is how we make decisions. If you express the HER2 protein, which you're either HER2 positive or HER2 negative, if you have it, then you're a candidate for these medications, trastuzumab and the other one. If you have a KRAS G12C, don't freak out. They're going to do these tests on you, and they will tell you, yes, you have a KRAS, and yes, it's a G12C. It's very simple. Either you have it or you don't. And if you do, you're a candidate for this medication. If you have a BRAF V600E, you're a candidate for this medication. If you have an NTERK mutation, you're a candidate for these medications. And if you are microsatellite instability high or MSI high, you're a candidate for immunotherapy. Very simple. You see, when you first saw this slide, it looked very confusing, but very simple. Doctor, do I have any specific mutations? No, you don't. Okay, you're not a candidate for these. Or do I have microsatellite instability? No, you're microsatellite stable. Okay, chances are no immunotherapy. Okay, yes, you do have a mutation. Okay, is it a treatable mutation? Which mutation do I have? Oh, yes, you do. You're a candidate for these medications. That's the way that we make treatment decisions if you have metastatic cancer. All right, let's go on to the next slide. Now, follow-up. We're almost done, so wake up. You're almost done. Look at how much you've learned. So in follow-up, we usually follow your labs, including your CBC, your CMP, and a CEA. So your CBC are your blood counts, your white cells, hemoglobin platelets. The CMP is your renal function, your electrolytes like your sodium, potassium, your liver enzymes, and your CEA is a tumor marker. Cancer, your colon cancer can produce this tumor marker, but just know that not all colon cancers produce CEA. So just because your CEA is normal does not mean you're cancer-free. No, because unfortunately, about 30% of colon cancers do not produce a CEA, and it's a simple blood test. And I have a video in my channel that's on tumor markers if you want to learn a little more about tumor markers. But we will perform these lab tests during chemotherapy, during treatment, during follow-up, just to see how you're doing, your liver, your kidneys are tolerating chemo, etc. The CEA, obviously, if your cancer produces CEA, because your CEA originally was high, we can follow it. And if your CEA is going up, it usually implies that your cancer is growing back. And if your CEA is high and we start you on treatment and your CEA is coming down, obviously it usually means that the amount of colon cancer is going down. Now just know that other cancers in your body also produce CEA. So it's not a great test, but it's a test that we use nonetheless because it's easy to perform and it's relatively inexpensive. Your imaging tests, so CT scans, bone scans, etc. Your doctor every so often, depending on what stage you are and if you're on chemo or not, they will perform these scans from time to time. Just ask them, how frequent will they be done? So just to make sure that your cancer is not growing back. No, we do not like to perform these tests because a lot of these tests do give off a little bit of radiation. So obviously, if we need to do them, we need to do them. Just know that it is a little tiny bit of radiation. But if you have frequent scans, that little bit of radiation starts to add up, and then you can have some issues with the radiation exposure down the line. But I don't want you to panic. It's very little radiation per scan. I also have a video on radiation from imaging tests if you want to learn a little more about this. And the last thing I want to go over here is ctDNA. This just means DNA, circulating tumor DNA. They might perform this, especially if you have metastatic disease or if you have high risk stage 3 or high risk stage 2 colon cancer. This is very simple. The circulating tumor DNA is a blood test where they try to find if you have tumor DNA in your bloodstream. And it's quite simple how they do it. They analyze your original tumor and they find what DNA does that tumor express, the DNA within the tumor that you had or have. Then they will look to try to detect this DNA if it's circulating in your blood. And obviously, if they find that same DNA that they took out of you in the tumor and they still find it in your blood, especially if they test serially and it's going up, it usually implies that the cancer is growing back. We don't always perform it. We do it from time to time. There are reasons for doing it, and but just know that this is something that you can ask your doctor. All right, so a recap. That's it. There's no more new info. I'm just going to tie it all in as I told you. So come on, you're almost done. I think we have 1 or 2 more slides and we're done. And it's very quick. The questions that you need to ask. The first question, what stage are you? If you're stage 1, usually surgery and you're done. Stage 2, surgery and no chemo unless, remember, you're high risk. Stage 3, you have surgery, and then we usually recommend chemotherapy. Stage 4, remember, you're metastatic, you're M1, so we usually give chemotherapy. Now, notice how I put chemotherapy plus or minus surgery. If you have cancer in the colon, and we know you have it, as an example, let's say you have it in your lung and your liver. If we remove the cancer in your colon, you're still going to have the metastatic cancer in your lungs and your liver. So if we do not have to perform surgery, a lot of times we will not. But there are times where your colon cancer may be so large that it might cause obstruction, or maybe your doctor is afraid that that colon cancer could perforate your colon, or maybe you're bleeding, or maybe it's causing pain, or there are many reasons. But if you have metastatic cancer and you did not have surgery, you have not had surgery yet, ask your doctor, do I really need to have surgery? Because sometimes we do not. Why put you through a surgery that they're going to remove this cancer in your colon and they're still going to leave cancer in the rest of your body? So we cannot cure you. So I don't know if that makes sense to you, but ask your doctor if you're stage 4, if you truly need surgery or not. Rectal cancer, remember, if you're rectal, it's different than the colon because chemoradiation to try to prevent that bag. Also ask, as I said, is the cancer on the right side or the left side? As already mentioned, the mutation test, especially if you have metastatic disease. Remember the KRAS, the BRAF, all these things you want to know, as well as do you have MSI high because of the immunotherapy issue? And if you are stage 4, what about removing your metastatic cancer? And I believe that we are done. So congratulations. I hope this made a lot of sense to you. Again, I did not cover everything because there's a lot of information that is way above this talk and it gets really complicated. But believe me, if you know what I just went over, you will know exactly what your doctor is telling you and you will be able to ask all the right questions. So I want to wish you the very best in your treatment journey and I want to thank you for your attention and I'll see you on some of my other videos.